Good morning, Kaylen. Thank you so much for being here.
Good morning.
We're so
It's a
excited.
pleasure to be here. Sorry, I'm seeing patients this morning, so I'm just like popping from room to room, and now we're ready to go.
Perfect. Yeah, I was waiting until I saw you in here to fully wrap up the last session, so I knew you didn't get stuck. I'll be brief on the
No, we are ready to go.
Awesome. And I'll be brief on the intro, just because we have a lot of great information to cover. And just for those of you that don't know Kaylen Silverberg is the founding partner at the Texas Fertility Center, one of the nation's leading full-service infertility practices, assisting patients throughout Texas, the southwestern United States, and the Americas. And we kind of joke that, if you talk to three infertility patients in Austin, 2 out of 3 has probably seen Kaylen or someone at his practice. Dr. Silverberg is committed to advancing medical breakthroughs in the field of reproductive endocrinology with a special interest in cost-effective care. In addition to maintaining clinical practice, he's actively involved in fertility research, has been published extensively in fertility medical literature, and serves on national infertility boards and consults for industry leaders. So super qualified. I think the topic that we're going to be talking about today with Kaylen is so important because there's a lot of misinformation, partial information, and a lot of confusion surrounding COVID as it relates to infertility, the vaccines, all of it. So he's going to kind of bust that open and give us the facts on it. So Kaylen, I will turn it over to you.
Thank you very much. You got to tell me, first of all, let me just make sure that you can hear me.
I can.
You hear me okay?
Yes, sir.
Perfect. Well, the first thing I want to do is I want to thank Dr. Bisbeck. I am quite shocked and overwhelmed by this fact that the Men's Center, Fertility Center of Austin, is sponsoring my talk. I'm very appreciative. Dr. Mystery is an amazing guy. He's an amazing fertility specialist. We're so lucky to be able to work with him. But what I would like to do now is move on to this topic. This is really kind of a fun topic for me. I usually talk about fertility-related things, but this is so timely right now because the virus, everybody's concerned about the virus and what's the effect that the virus is going to have and can it affect my fertility? And now, fortunately, thank goodness, we've got vaccines out. And the question is, okay, now what about the vaccines? What are they doing? Are they going to be beneficial? Or are they going to be problematic? So I'm going to talk to you guys for the next few minutes about COVID-19, the virus and the vaccines. And then I'm hopefully going to leave a little bit of time at the end so we can have some questions and answers. So what is COVID? Well, it's a novel coronavirus. It's called the SARS-CoV-2 virus. It's a novel coronavirus, which means it's never been seen before in humans. Having said that, we know that coronaviruses themselves are not new. So there was a virus that caused an infection called SARS years ago, and another virus that caused an infection called MERS, Middle Eastern Respiratory Syndrome. And those are both coronaviruses also. And we were able to develop effective treatments against those. So it's not a surprise that we were able to develop vaccines against the SARS-CoV-2 virus as well. So while COVID can cause significant symptoms, it's rarely fatal in the absence of risk factors. And I'll show you this in just a minute. I'm going to show you some data from China. And I'm a data guy, so I'm unfortunately going to show you a bunch of data. And I'm going to walk you through it so that hopefully you'll be able to understand it. But in the absence of risk factors like cardiovascular disease, high blood pressure, obesity, diabetes, advanced age, and cancer, COVID is really rarely fatal. And again, we'll talk about that in a few more minutes. This is an electron microscopic picture of the actual virus. What you can see is the virus is in the middle. It's that white thing. The red things on the outside are what have become famous. Everybody knows now about spike proteins. This is actually called an S protein or spike protein. And it is that protein, that red thing on the surface of the virus, that allows the virus to bind to host cells to begin to wreak havoc. And so the interesting thing that these geniuses at these pharmaceutical companies that have come up with these vaccines in record time, by the way, the thing that they really focused on is how can we make an antibody, make a vaccine to this particular virus that will be very effective and very safe. And what they chose to do was they chose to make a quadrivalent, quad means 4, they chose to make an antibody that attacks 4 different sites on that S protein. So when you hear about variants of the virus, which we'll talk about at the end of my talk, the odds of one of those sites being altered as the virus mutates, pretty good. The odds of 2 of those sites being altered, also pretty good. But the odds of 3 or 4 of those sites in that virus being altered through mutation is very, very low. And that's why, as you'll see, the reassuring part of the variant discussion is that the vaccines still work even against the variants that have been known so far. So moving on to symptoms of COVID, well, the most common symptoms, fever, dry cough, and fatigue. Less common symptoms, loss of sense of taste and smell. It seems like everybody has that, and that's kind of the pathognomonic thing. So that if you lose your sense of taste and smell, boom, everybody assumes that you've got COVID. Not true. There are lots of different other viral infections, including the flu, including a lot of upper respiratory tract infections that can cause you to lose your sense of taste and or smell. So that is not it does not mean that if you have that you've got COVID. Other less common symptoms, headaches, GI symptoms, sometimes some vomiting, diarrhea, sore throat, muscle and joint pain. Symptoms usually develop within 5 to 6 days of exposure. So if you've been around somebody who had COVID and you make it past 5 or 6 days, odds are pretty good you dodge that bullet. If you look at infection and death rates, these are in the millions. Looking on the far left part of the graph, you can see worldwide, as of a couple of days ago, there have been 137 million people infected with this virus. It's just an astronomical number. But when you think about the world's population, it's still a relatively small number. When you look at the people who have died worldwide, it's almost 3 million. And I'll talk about death rates in just a second. When you look at the United States, what you can see here is 31 million people infected. And I can't see the bottom of my slide there, but let me see one second. See if I can hide that. Yeah, 31 million people infected in the United States, and about 570,000 so far have died. That's as of yesterday. If you look at Texas, there have been 2.8 million people out of 29 million people in our state. So a little less than 10% of the population of Texas has been infected, and we have had just about 50,000 deaths in Texas. Still, it's a horrible number, but fortunately not as bad as was predicted. If you look at the far right side of my slide over here, you can see death rates. The worldwide death rate, and this is if you look at everybody, and the way we define death rate is the number of people who died from COVID divided by the number of confirmed cases of COVID. Why am I saying confirmed cases? Because there are a lot of people who have COVID who are asymptomatic, and they're not a confirmed case. There are a lot of people who have minimal symptoms. They don't get tested. They're not a confirmed case, but in fact, they had COVID. So if we included those numbers of people in the denominator, the death rates that I'm showing you over here would be even lower than what I'm showing. Okay, this is the highest possible death rate based on the equation that we use to determine what it is. So the worldwide death rate from COVID is 2.19%. That means if you have 100 people worldwide who are infected, a little over 2 are going to die. In the United States, the death rate is 1.8, and in Texas, it's still a little bit lower at 1.78. Okay, and again, this is all people, all ages, from infants all the way up to to people in their 90s. This is an interesting graph that looks at, or a table that looks at case rates, hospitalization rates, and fatality rates by age. And what we've done here is all these numbers are going to be compared to the risk of somebody in the index group, which are people 5 to 17 years of age. So this is the reference group for all of these things. And what I'm telling you, or what I'm trying to show you in this table is, if you look at cases, the risk of you getting infected, if you're 18 to 29, is twice as high as it's the risk of you getting infected if you're 5 to 17. But interestingly, look at age 65 to 74 and 75 to 84. The risk of getting infected is no greater than if you're 5 to 17. And there's lots of variables that interfere with and interact with the case rate. But let's look now at something really important, hospitalization and death rates. Again, if you say that the age group of 5 to 17 is our reference group, okay, if you're 18 to 29 and you're infected, you are 6 times more likely than anywhere between 5 to 17-year-old to be hospitalized. If you're 50 to 64, you're 25 times more likely to be hospitalized. If you're 75 to 84, you're 65 times more likely to be hospitalized than a teenager. Okay, and if you're 85 or over, you're 95 times more likely to be hospitalized. Now look at death rates. Okay, if you're 18 to 29, you're 10 times more likely to die than a teenager. Okay. Again, that number is very, very, very small. This is not that 1.78% that I showed you from Texas. That represents everybody in this entire table. But my point is, is that as you get older, okay, you can see the death rate significantly rises. So if you're 65 years old and you get infected with COVID, you have a 1,300 times greater likelihood of dying from that infection than a teenager. And look, if you're 85 years of age or older, 8,700 times. This is why it's so important to protect our elderly population, not only with the vaccination, but with isolation and with all kinds of protection. This is data from China looking at the likelihood of death if you had specific underlying conditions. So if you had cardiovascular disease, for example, heart disease, what this says is 10.5% of people with cardiovascular disease who were diagnosed with COVID-19 died. So cardiovascular disease, diabetes, chronic respiratory disease, high blood pressure, and cancer, okay, were the most likely factors that would lead to a poor outcome. And if you look at the data in China, if you had no underlying health condition, you had less than a 1% chance of dying from the infection. If you look by country, you can see on the x-axis down here, these are dates. This is from March 14th of 2020 all the way over to April 14th of 2021. And what you can see is in certain countries, like Italy, for example, the initial rate, case fatality rate was really high, and then it started to come down significantly. If you look at the United Kingdom, really high, it peaked out at some of the highest in the world, and then fell precipitously. And if you look overall, you can see the death rate in China is still very high, 4.75%, Iran 3%. If you look at the worldwide death rate now, as I showed you before in that other table, it's about a little bit over 2%. United States is at 1.8%. And there are a few countries that have done better than the United States. India, for example, the death rate is 1.23%. New Zealand, the death rate is only 1%. And Israel leads the world with a death rate of only 0.75%. So let's talk now about the vaccines. Well, the vaccines are really interesting and really important. And again, thanks to Operation Warp Speed, these vaccines were developed and approved in record time. It typically, from my reading the literature, takes about 5 years on average, the time a vaccination is discovered and developed until the time it's approved and administered. And here we are, 7 months after development of the vaccines, and we're already getting shots in people's arms. There are 4 basic vaccines that are relevant to the discussion. One's made by Pfizer, one's made by Moderna, one's made by Johnson & Johnson, and the other's made by AstraZeneca. The AstraZeneca vaccine is not FDA approved. The other 3 are. Pfizer is FDA approved for age 16 years of age and older, although last week they submitted a request to have it approved to be administered to people between the age of 12 and 15. Moderna is approved only for 18-year-olds and up. Both the Pfizer and Moderna vaccines require 2 doses, and they are stable for 6 months at 20 degrees below zero and stable for 30 days at 2 to 8 degrees centigrade. And that's important because these are very, very cold temperatures. So these vaccines have to be kept very, very cold in specialized freezers. Okay, and once they're thawed, they've got to be used. The Johnson & Johnson vaccine is different. It only requires 1 dose, and it's stable for a much longer period of time. It's stable for 2 years at 20 degrees below zero centigrade and stable for 3 months at 2 to 8 degrees centigrade. So what can I tell you about the vaccines? Most vaccines work because we inject inactivated, dead, or small non-functional pieces of a live virus into the body. Your immune system recognizes these particles as foreign, and then you mount an immune response by producing antibodies against that particle to try and destroy it. So anything that goes in your body that's not your DNA, with the exception of pregnancy, which is a fascinating conversation in and of itself, but anything that goes in your body that's not your DNA is recognized as foreign, and your body will attack it. You have antibodies called memory antibodies that circulate throughout the body. They find and they bind to the specific particles in question, and then they form this particle and antibody complex together, and then that's excreted from the body and removed. And those memory antibodies stay around for variable periods of time. And when we talk about boosters in a little bit, that'll become relevant. So for example, when you get a tetanus vaccine, you only need to get a tetanus vaccination, a booster, once every 10 years. Well, why is that? It's because the memory antibodies last for a very long period of time. When you get the flu shot, for example, though, you're supposed to get that every year. Or the shingles vaccine, you're supposed to get on a regular basis also. That's because the memory antibodies that develop in response to that challenge don't last as long. We don't know yet how long the antibodies are going to last in response to the COVID vaccine. They may last a year. We know for sure they already last longer than 6 months, but they may last a year, so you may need a booster every year. They may last 5 years. You may not need a booster for 5 years or longer. So this is still work that's being performed now. So antibodies then continue to circulate throughout the body looking for any new particles that may appear after another exposure. So say, for example, with this COVID vaccination, that you get vaccinated and then you get exposed to somebody. Well, your antibodies are all revved up already. So it's very easy for your body to crank out even more antibodies really rapidly in response to that challenge of infection. Once that infection's cleared, say a month later, you're exposed again. Well, again, your antibodies are already revved up and they will very effectively be able to bind to that virus and get rid of it. So any new infection causes a quick ramp up in antibody production to prevent or fight off a new infection. So let's talk about the differences between the vaccines. The traditional way of making a vaccine, like I said before, is where you attach either a piece of a dead virus or a piece of an inactivated virus or a small piece of a live virus. You attach that to a different type of a vector. In this case, they use adenovirus, which is a very common upper respiratory virus. And that vector carries that piece of viral DNA into your body. And then your body responds to that and makes antibodies to it to destroy it. So Johnson & Johnson and AstraZeneca went the traditional route. And that is how they made their antibodies. So these antibodies are just like the tetanus antibody, just like the flu antibody, vaccines rather, the tetanus vaccine or the flu vaccine. So it's a very traditional, very common way of making vaccines. Johnson & Johnson uses a human adenovirus. AstraZeneca chose a chimpanzee adenovirus. It doesn't really matter. They all work the same way, and they're bound to these particular parts of the COVID virus to get it into the body. With the advent of Operation Warp Speed, though, Pfizer and Moderna decided that they were going to make their vaccines using a different methodology, and it's really ingenious. So what they did was they took a lipid nanoparticle. Lipid is a fat. A nanoparticle is a very, very, very small structure. So they took these lipid nanoparticles and they took out a little bit of messenger RNA from the COVID spike protein, the S protein. And they did this at 4 different sites. And they took that mRNA, put it into the lipid nanoparticle. And that's what the vaccine is. So when you get a shot of the Pfizer vaccine or the Moderna vaccine, what's happening is you're being injected with these lipid nanoparticles that contain the messenger RNA from the virus. No virus is being injected into you. This is why it's impossible, literally impossible, to get COVID from the vaccine itself if you get the Pfizer or Moderna vaccine. If you get the Johnson & Johnson or AstraZeneca vaccine, you have a very low risk of actually getting the viral infection. But again, with Pfizer and Moderna, the risk is 0. The nanoparticle then, when it enters your body, it fuses with a host cell, and it releases the messenger RNA into the cell. That messenger RNA, importantly, does not enter the cell nucleus. So unlike other infections, it does not take over that cell. Rather, it stays in the cytoplasm of the cell, and without making your eyes roll back into your head, it binds to something called rough endoplasmic reticulum and also to proteins called ribosomes. And those are the factories that cause translation of messenger RNA into protein. So that's what causes protein production. This messenger RNA codes, it tells the host cell to make the spike protein or to make different pieces of the spike protein. Those little pieces of protein go onto the surface of that host cell, and that's what initiates the reaction, the antibody reaction in your body. So when this reaction occurs, these cells on the surface of the host cell, or these proteins on the surface of the host cell rather, make protein. They generate antibody production because they make chemicals called cytokines. And these cytokines spin up and they cause the production of antibodies that then go back and attack these S proteins. And now not only do they attack those S proteins that are on the surface of the host cell and kill the host cells, but now they're circulating in your body looking for any evidence or any site of infection where you might be infected with the virus itself. And when you are, immediately those antibodies go to that virus, they bind to that S protein, they destroy it, and it's excreted from the body. So now, what do our professional organizations say about all this? Well, in January 8th of 2021, the World Health Organization came out with their first of 3 statements on the vaccination. And they said, quote, there are specific populations for whom vaccination is not recommended, either due to contraindications, lack of supply, or limited data. These populations currently include people with a history of severe allergies, most pregnant women, and international travelers who are not part of a prioritized group, and children under 16. So the World Health Organization in January of 2021 actually came out totally against everybody else and said pregnant women should not be vaccinated. A month later, February 19th, they came out and they said those pregnant women at high risk of exposure, for example, health workers, or who have comorbidities which add to their risk of severe disease like diabetes, high blood pressure, heart disease, may be vaccinated in consultation with their healthcare provider. So a month after their initial statement, they softened their statement. That was on February 19th. And then most recently, on March 31st, they came out with their third statement, now coming around to where the rest of the world has been since the beginning, saying pregnant women are at a higher risk of severe COVID-19 compared with women at childbearing age who are not pregnant, and COVID-19 has been associated with an increased risk of preterm birth. The available data on vaccination of pregnant women are insufficient to assess the vaccine efficacy or vaccine-associated risks. However, it should be noted that the messenger RNA vaccines, in other words, Pfizer and Moderna, don't contain any live virus, and the mRNA does not enter the nucleus of the cell and is degraded quickly. In addition to that, DART studies, stands for Development and Reproductive Toxicology Studies. These are studies that are done all the time looking at vaccines. Those studies in animals have not shown any harmful effects in pregnancy. The World Health Organization now does not recommend delaying pregnancy following vaccination. So the World Health Organization is kind of slow to the party, as you'll see in just a minute. What does the Center for Disease Control say? Well, on March 18th, they said if you're trying to become pregnant now or want to get pregnant in the future, you may receive a COVID-19 vaccine when one is available to you. There is currently no evidence that any vaccines, including the COVID-19 vaccines, cause fertility problems. The Center for Disease Control does not recommend routine pregnancy testing before COVID vaccination. And the reason is they're not even worried about it. And they finalize by saying if you're trying to become pregnant, you do not need to avoid pregnancy after receiving the vaccine. So the Center for Disease Control has blessed this. And not to get political, but this is comforting to me because the Center for Disease Control is usually right. The World Health Organization, unfortunately, is usually wrong. Now, what do our professional organizations say? Well, the American College of OB-GYN on January 27th came out with a statement. This says both COVID vaccines currently authorized by the U.S. Food and Drug Administration, at the time that was Pfizer and Moderna, should not be withheld from pregnant individuals who choose to receive the vaccine. In other words, get vaccinated. What does the American Society of Reproductive Medicine say? Well, we affirm our continued support of the recommendations of the ASRM COVID Task Force as reported in update number 12, dated January 18th of 2021. And what that said was the COVID-19 vaccination is recommended for women who are contemplating pregnancy or who are pregnant in order to minimize the risks to themselves and their pregnancy. So everybody except the World Health Organization from the beginning has said get vaccinated because from the beginning the data showed no increased risk. And the World Health Organization, even they are now coming around. So what about efficacy data? If you look at the data from the clinical trials now, Pfizer and Moderna have an efficacy rate of at least 75%. AstraZeneca is 76% from their trial, and Johnson & Johnson, one dose is 66.3%. All 4 vaccines are highly effective in preventing hospitalization and death. Okay, this is showing you the likelihood that it will prevent infection, but the likelihood that it will prevent severe infection, hospitalization, or death even higher. Okay, unfortunately, no original trials for Pfizer or Moderna vaccines included pregnant women. And this was despite the fact that the Center for Disease Control, ASRM, and A all did have been included, but the Federal Food and Drug Administration said no. And so Pfizer and Moderna were studied without pregnant women. We do know that the preliminary developmental and reproductive toxicity studies, DART studies, are encouraging. Animal studies do not indicate any abnormalities in either female reproduction or fetal development. We know that pregnant women infected with COVID-19 experience more severe symptoms and a higher risk of death compared to non-pregnant peers. And then I talk a little bit about the, what's been stated before. The CDC says that no unexpected pregnancy or infant outcomes have been detected as of March 1st among pregnant women who received the vaccine. And as of March 29th, there are 69,000 documented pregnant women who received either the Pfizer or the Moderna vaccines in the United States alone. 4,000 of those women have enrolled voluntarily in an ongoing registry. So they'll be followed throughout their pregnancy, and then their babies will be followed for up to 5 years after delivery. So eventually we'll have all the information we need. There are also some studies that have come out recently that suggest that immunity, so if you get the vaccine and you're now immune, you can pass that immunity on to your fetus. Several studies suggest that now, and we know that vaccine-induced antibody levels are equivalent in pregnant and lactating women compared to non-pregnant controls. So when you're pregnant and when you're breastfeeding, there's always a question of, do antibiotics, for example, do vaccines work the same way? And we know now that they do. So you produce the exact same antibody levels if you're pregnant or if you're not pregnant. You produce the exact same antibody levels if you're breastfeeding or if you're not breastfeeding. We also know that antibody levels resulting from vaccination are strikingly higher than levels that result from the COVID infection itself. And this is a study of 130 pregnant women. And so this is important because we know that the antibodies that you produce from the vaccine are at least as good, and in fact, in this study, are actually better. We also know that antibodies generated from the vaccination have been isolated both in umbilical cord fluid, umbilical cord blood, and in breast milk. And this shows the mechanism. So when you come up with a thought, you've got to come up with a mechanism behind it. So if we're saying, okay, you know what, it looks like immunity can be passed from a woman to her breastfeeding baby. Well, what's the mechanism? Well, now we know, because the vaccine and the antibodies, rather, are found in breast milk. And we know that immunity can be passed from pregnant women to their babies before delivery even, because the antibodies have been determined and isolated from umbilical cord blood. So where are we now? What's the current status of the vaccine? And what's the number of patients who've been fully vaccinated and the percent of the population? Well, worldwide, 180 million people have been fully vaccinated now. That's unfortunately a small fraction of the population. It represents 2.3% of the world's population. If you look at the United States, 75 million people out of 320 million have been fully vaccinated. That's about 23%. And if you look at Texas, we're lagging slightly behind. We had 5.8 million out of our 29 million residents who've been fully vaccinated, represents 20%, but we're getting there. Okay, let's move on and talk about variants. There are currently 5 variants that have been detected. The first one that was detected was the second one here, the B.1.351, and that was detected in South Africa. And it was determined to be less sensitive to monoclonal antibody treatment and autologous antibody formation. So in other words, there's a little bit of resistance to the vaccines, but the vaccines are still effective against these variants. And let me just emphasize, the vaccines so far are successful and effective against all 5 of these variants. But like I said, there are now 5 variants, one from the UK, one from South Africa, one that's been detected in Japan and Brazil, and then 2 that have been detected in California. All variants appear to spread more easily than the native original wild type COVID virus. And thus far, no variants have been determined to be totally resistant to the approved vaccines. So everybody who's been vaccinated should be covered. And I can assure you, Pfizer's already come out with statements that they're already working on vaccines specific to the variants, and they're planning on their boosters containing multiple antibodies, not only to the native virus, but also to these variants. So what about boosters? While some vaccines do not require boosters, like rubella, you get rubella vaccine when you're a kid and you're protected throughout life. Same thing with polio. Most vaccines do. So for example, tetanus, you got to be vaccinated every 10 years. The flu, you've got to be vaccinated every year. Same thing with pneumococcal pneumonia, meningococcal meningitis, shingles. All those things require regular boosters. So therefore, it's common and reasonable to expect that boosters are going to be required for COVID-19. So let me end up by talking about the concerns that we do have and concerns that are theoretic. So when you look at the Johnson & Johnson vaccine, as of 3 days ago, there were 6 reported cases of blood clots in over 6.8 million people who had received the Johnson & Johnson vaccine. This is literally a 1 in a million event. Okay? All of the women, all 6 of those women, or first of all 6 of those people who got blood clots were female. And all of them were between 18 and 48 years of age. And as it turns out, almost all of them, I think 5 out of the 6, were on birth control pills or on estrogen, both of which are known to raise your risk of blood clots anyway. And all of these effects occurred within between 6 and 13 days after vaccination. So what does this say to me? This says to me that any halting or pausing of administration of the Johnson & Johnson vaccine is a political decision and not a medical decision. You don't stop something. You know, in fact, in a package insert for any kind of a drug sold in the United States that's approved by the Federal Food and Drug Administration, you don't even have to mention a side effect that occurs in less than 1% of the population of people that take it. And now, because of an event that's been reported in less than 1 in 1.1 million people, there's a call for the Johnson & Johnson vaccine to be shelved. Makes no scientific sense, and I can't explain it. AstraZeneca is a little bit more of a problem. As of April 15th, there were 469 cases worldwide of blood clots in association with low platelets. That incidence is also lower than expected in the general population. So again, this is probably or quite possibly going to be explained by just, luck of the draw. This is something that doesn't occur any greater than it occurs in the general population who's not been vaccinated with the AstraZeneca vaccine. The other thing that's a little bit concerning is there's a very rare condition called cerebral venous thrombosis, and that has been reported now following the AstraZeneca vaccine in 168 cases out of the 34 million people who've taken that vaccine. So theoretic concerns, what about that? Well, it's this theoretic concern about a potential effect on fertility. It is true that some pieces of the genetic sequence of the spike protein resemble some pieces of the genetic sequence of a protein called syncytin 1. And syncytin 1 you've never heard of, but it's a protein that's involved in attachment of the placenta to the uterine lining. So the concern, theoretic only, is that maybe antibodies could interfere with implantation. There is absolutely no evidence that this is correct. This is purely a theory. It has never been tested. It's never been demonstrated so far. So far, the incidence of miscarriage in women who've received the vaccine or had the virus is no greater than the general population. The only risk that appears in pregnancy is preterm labor and preterm delivery. There are several small reports suggesting a potential decrease in sperm counts in men who've been exposed to the virus or been infected. This is going to be very difficult to study because we already know that sperm counts are decreasing in the general population worldwide. And then finally, there's a small report that suggests that guys who've been infected with COVID have a 3-fold greater increase in erectile dysfunction. Again, erectile dysfunction is multifactorial, may or may not turn out to be related. But they're the only concerns so far that have even been raised. So therefore, what's the bottom line? The virus has only been recognized for 17 months. 18 months ago, nobody on the planet, maybe outside of people in Wuhan where it first occurred, but nobody else on the planet had even heard of the COVID-19 virus. It's only been out for 17 months. Amazingly, the vaccine's been out for 6 to 7 months. It's way too soon for us to know everything about the long-term effects of either the virus or the vaccine. And realistically, it may take 5 to 10 years for us to know everything we need to know about safety and efficacy. In the meantime, and I bolded this, in the meantime, all available evidence suggests that these vaccines are both safe and effective, and all of our professional organizations suggest that if you're pregnant, if you're trying to get pregnant, if you've delivered and are breastfeeding, you should be vaccinated. So that's it. Tried to rush through that, but I appreciate the opportunity to speak with you all today. And if you all have any questions, I'd be happy to take them.
Kaylen, I did have a couple people, and we'll just go quick because I know you've got patients waiting for you. Just, again, I get it's always something political or, an agenda out there. But what about the people that are worried about, the side effects 10 years down the line, the commercials that say, if you got the COVID vaccine and you XYZ, that's the one. I had like 3 people ask versions of that.
Yeah, I mean, there always is going to be underemployed lawyers, right? And they're going to be advertising at 2 in the morning. If you know anybody who's been exposed to this, call this number. There's nothing anybody can do about that. You know, I mean, when you practice medicine, this is just a fact of life. We deal with this on a daily basis, and you just have to deal with it. You have to do what's right. And you know, if there are going to be people out there who are going to try and point fingers because they see an opportunity for themselves, you can't do anything about that. It's just the way it is.
Fair enough. Well, is there anything? Comments very informative. Thank you so much. Great presentation. Is there anything that you would like to leave us with for the event or on the topic?
Yeah. Yeah. Well, first of all, I just want to congratulate the foundation. I'm so proud of what you guys have done. I'm so proud of what you guys do, you know, every single year. The unbelievable number of people that you're helping. Your cause is so noble. And I just am grateful to be associated with it. I really appreciate the invitation to be here. You know, my patients hear it all the time, all day, every day. Pregnancy it's one of those rare things. I'm sorry, infertility is one of these rare things. You know, nobody stands in the infertility line to get it any more than they stand in the diabetes line or the cancer line or the heart disease line. And it is a bummer to be affected with infertility. But what I would leave you with is that unlike almost every other disease known to mankind that is not curable, infertility is curable. Every time we look at the data, we know that 80 to 88% of people who walk in the door and stick with the plan walk out pregnant. So I just congratulate people who have the fortitude to be able to go through fertility treatment. I congratulate you guys on doing what you're doing, and I can't thank you enough for the invitation to be here today.
Awesome. Well, we certainly appreciate you and tell your patients we appreciate their patience and letting you speak with us. Have a great rest of your day.
You too. Thank you so much again.
Thank you. Bye-bye.
Bye-bye.